Hey everyone, welcome to the Slice of Healthcare podcast. I'm your host, Jared Taylor. Today I'm here with Dr. Joel Diamond, the Chief Medical Officer at 2bPrecise. How are you today?
Excellent. Nice to be with you today, Jared.
I'm excited to chat. I think we should dive right into it since we like to keep these short and sweet for the audience so they can consume as much as possible. If you could tell the audience a little bit about yourself, and then we can go into a little bit about the why, how, what of 2bPrecise, we'll start our conversation today.
Perfect. I'm Joel Diamond. I'm the Chief Medical Officer for 2bPrecise. On my day job, I'm a family practitioner. I've been practicing family medicine for about 30 years in Western Pennsylvania. I'm involved in medical informatics for a good deal of that career as well. 2bPrecise was a company we founded to solve some IT problems and information problems associated with this expanding field of precision medicine. And in a nutshell, what we do is we acquire data from multiple genetic and other laboratory sources. Today, most of that data is coming back as a PDF or on paper somewhere that's going into a folder that's labeled other. And we've sort of gone backwards in terms of information technology because most of that data is not represented discretely in the electronic record. So we're acquiring that data in real time as discrete data. We're also in near real time collecting clinical data and putting this in a combined hybrid data model that we call a cross-clinical omics repository. And at the same time, we're hooked up to ever-changing knowledge sources, recognizing that this precision medicine field is moving ahead so very, very rapidly. Being able to then do the real hard part is injecting that knowledge at the point of care, regardless of what venue that user is working in, whether it's Epic or Cerner or Allscripts. It doesn't really matter in the context of what they're doing, either making recommendations and clinical decision support, or vice versa, having clinical conditions look at existing genetic data and new knowledge to be able to inform them as well.
Now, when we think of drug gene testing, can you talk us through why it plays such a large role in pediatric care in particular?
Sure. So it certainly does across the board. And adverse drug reactions is a problem, whether we're talking pediatrics or adult medicine. The implications clearly for pediatrics play a much bigger role. I would also say that we have less tolerance for potential drug gene interactions in the pediatric population. Why? If I look at an area like behavior medicine, the time from diagnosis to correct treatment of a condition like depression is important in all age groups. But I would say that in the pediatric population, it's even more of a time crunch. We have, as we look at the crisis in terms of teen suicides, how children do in school, et cetera, we've really got to condense that time frame down considerably. There's other implications too. With this, as we look at other pediatric diseases, whether they're rare diseases or otherwise, the time to treat is often dependent on getting the right genetic diagnosis and getting the right genetic profile for treating them with medications.
And can you talk us through, and I know I'm focusing on pediatrics, but it's definitely, I think, I've been reading more about just the focus in on that space. I feel like we always hear about a lot of the other spaces within healthcare, but even more so maybe now where there's more startups coming up in the pediatric space, right? Can you talk us through the risks associated with failing to implement within the pediatric population?
Sure. And there's a couple of them right now. One of them, we can go back a while. We've eliminated in certain care certain classes of drugs for both good and bad, but some of them we've done with a very broad brush. An example of that is it's rare to use codeine as an analgesic in the pediatric population because of a high rate of adverse drug reactions. Most of those happened in patients that were susceptible from a pharmacogenomic standpoint. And that's an example of a drug that we probably didn't need to eliminate altogether if we properly found the right candidates to use that. Now, I'll get away from the whole issue of using opiates, et cetera. But if we look in lots of other areas, we can look at the neonatal ICU and the time it takes for patients, particularly with seizure disorders, to get on the first, second, sometimes seventh line drug in order to control those seizures. Reducing the time in the NICU is an example of where the cost savings are just immense. A single day in the NICU more than justifies the cost of these drugs. And then as we start looking across disciplines, a lot of times we haven't considered the effects of pharmacogenomics on more efficiently treating pediatric heart disease, et cetera. I still maintain in the area of behavioral health, this is probably the biggest impact for organizations.
Uh, Now, I don't want to sound like a broken record continuing to focus in on this, but that was, one of the reasons we can hopefully have you on again to talk about some of the other areas and some other topics, but this was really a pediatric focus. So thank you for being cool with my questions related to that space.
Not a problem.
Uh, so could we talk a little bit about the financial benefits of genetic testing within pediatrics?
Sure. There's a couple of them. I'll start again because it's near and dear to my heart as a family practitioner in the behavioral health area here. First of all, if we just look at the normal cycle of prescribing a drug, waiting for it to work 4 to 6 weeks, then adjusting the dose, waiting, adjusting the dose again, maybe changing, maybe adding a second drug, and then adding a third line drug. As we move through that progression, now we're getting into more expensive drugs. We're looking at prior authorizations. We're looking at more utilization of healthcare services, et cetera. So that's sort of a no-brainer in terms of the cost of medicines, the number of visits, et cetera, let alone the most important part is the social implications of that. On the other hand, too, I mentioned this seizure treatment as an example of, well, if we look in hospitalized patients, clearly getting to the right drug at the right time is important. And then overall, and again, focusing on that pediatric population, adverse drug reactions, there is plenty of data in terms of where that adds to the cost of medicine on many, many levels. And doing the not so fine tuning, some of the coarse tuning around picking the right drug the first time, or certainly the second time, and avoiding adverse drug reactions. This is the time we've hit that point where pharmacogenomics, as an example, needs to be part of that paradigm.
And how could failing to acknowledge like drug gene interactions, how could that continue to like increase care costs and staff use over time?
Yeah, sure. So we spend a lot of money on a lot of quality initiatives today, whether they involve rare diseases, as an example, or they involve relatively common things. And again, behavioral health is an example of that. Hospitals and health systems and health plans spend a lot of money in the area of some of these chronic disease management areas today. And a lot of those costs can be taken out by really making sure that we're using the right drug. The idea of using a trial and error method to pick a medication, whether it's for heart disease or whether it's for attention deficit disorder, et cetera, those days really have to be over with right now. They make no sense from a financial standpoint, and they certainly make no sense from just how we practice good quality medicine today.
And real quick, Dr. Diamond, what is next for 2bPrecise that you can share?
Well, a couple of things. One is, and one thing I'd like to add to the last question, which I probably should have, which is, the cost of doing this test continues to come down at such an amazing rate, and we're talking about in the pediatric population doing a test once, perhaps, and then extrapolating that over the cost of a lifetime, which we don't do in almost any other laboratory test today. And the idea of starting at the beginning of a child's journey or their genetic odyssey if they have medical problems, and extrapolating those costs really gets into this. In the pediatric pharmacogenomic space, where we are right now, is expanding a lot of our offering in a couple specialty areas. One is identifying populations. One of them would be an example of treatment-resistant depression. The other one is expanding not just the drug-gene interactions, but the drug-drug-gene interactions. And those are often much more complex, and they're much harder to express at the point of care with a physician. So enhancing clinical decision support is another tool that we're doing, as well as looking into doing some more population health management around medications as well.
Well, Dr. Diamond, I want to thank you for answering every single one of my questions perfectly. And you were concise. You gave the audience exactly what they wanted to hear. So I appreciate that. I know that seems like it is a big thing because that doesn't always happen. So really, really appreciate you and everything you and the 2bPrecise team are continuing to build. Hopefully we can have you and other members of the team on in the near future, and we can talk about some things other than just the focus on pediatrics, because I know it goes much more broadly than that. But I do think our audience and even some of our past guests, right, that have been in the pediatric space, we had urgent care that focused on pediatrics, telehealth that focused on they're going to love to tune into this episode as well. So thank you so much.
Great. Thank you very much. It's been a pleasure.